Welcome to Spine Time. My name is Roger Härtl. I'm the Director of Spinal Surgery at Weill Cornell Medicine in New York. And today I'm your host and moderator for the second Spine Time webinar for patients. And today we have a very challenging and also exciting topic, the source of your pain, of your neck pain and back pain. How do we collaborate in the spine center to find out where your pain is coming from? And I can tell you that this is a really exciting topic, and some of these stories are really detective stories, like Sherlock Holmes detective stories, and we'll talk about this a little bit more. As you all probably know, we are located on 59th Street and 2nd Avenue, the Center for Comprehensive Spine Care at Weill Cornell. And not only do we have amazing surgeons there, and we specialize surgically on minimally invasive to complex to most complex spinal surgery, covering really all types of pathologies. But the pride is really for us that we have all these other subspecialties that we work with. They take care of all the other aspects of spinal care that we provide for our patients. We have rehabilitation medicine, physiatry, sports medicine. We have pain management. We have obviously surgery, neurology, and we work very closely with integrative health and complementary medicine at Weill Cornell to really be able to provide our patients the best comprehensive care, not only for diagnosis, but also for treatment and for recovery of their spinal problems. Now, I'm proud and happy to be able to introduce to you our two faculty and our two speakers today, and they both are co-directors of the Spine Center. On the left here, Neel Mehta. He is a board-certified pain management specialist and one of the co-directors of the center within pain medicine. He's going to talk about some of the tests and procedures that we can do in order to figure out where your pain is coming from. On the right, we have Josh Weaver. Josh Weaver is a board-certified neurologist in the Spine Center, and he's going to talk about neurological exam and all the things that he does in order to figure out exactly where your pain is coming from. Now, we'll get started by summarizing some of those issues that can cause back pain, and I'm sure many of you are probably familiar with some of these pathologies, unfortunately. And I show you an x-ray here on the right side of the lumbar spine. And this patient here has degenerative disc disease at the lower part of the lumbar spine. That could be a cause for low back pain. Now, this is an MRI scan of the lumbar spine that shows that the disc at the bottom part of the spine is degenerated. Patients can have disc herniations. Like this is a patient, a different type of patient that we treated who had a large herniated disc at L5-S1. Lumbar spinal stenosis, spondylolisthesis, those are all things that you've probably heard about. And these are all entities that can cause significant, not only pain, but also sometimes neurological problems and weakness and paralysis. Now, obviously trauma, you fall, you hit your spine, your back, your neck, you can have pain or even fractures from that type of injury. Facet joint pain, sacroiliac joint pain, and then obviously red flags. If somebody has a significant infection of the spine or a tumor, those are all things that we have to take into consideration. We've got to make sure that we don't miss some of those really more severe and more significant diagnoses in working up your symptoms and your pain. And muscular pain is also a source for pain that is frequently overlooked. Now, I'll show you a normal MRI scan here of the lumbar spine. Many of you have been in one of those machines. They're very loud and can be quite claustrophobic. I've had MRI scans done myself, and I know that it can be quite panicky lying in there. So you can see here the lumbar spine, the levels are numbered L1, L2, L3, L4, L5, and then the tailbone at the bottom. In between the bones in the front and in the back are the spinal nerves that are traveling up and down, and those spinal nerves can be compressed, which can cause pain or which can even cause sometimes neurological deficits. And this is a normal MRI scan looking at the lumbar spine of a patient lying down. We were looking from the feet towards the head. You can see the bone and the disc in the front, the bones in the back, and those little dots, those are the nerves traveling up and down in your spinal canal. And sometimes you can have compression of those nerves, which can cause pain. And the challenge is for us sometimes to figure out exactly which nerve is compressed by what type of structure and how can we diagnose and treat that. And this is a drawing that summarizes some of the abnormal findings that we see in patients who have severe disc degeneration or severe lumbar problems. They can have a degenerated flattened disc. They can have a bulging disc here that can be pushed back, touching the spinal nerves. Bulging discs we hear about all the time, but typically they don't really cause significant problems. However, if a bulging disc turns into a herniated disc that is much, much bigger, that can cause severe nerve compression and pain and weakness. And then we can have disc degeneration with osteophytes or bone spurs, and that can sometimes also cause pain if it's touching or compromising various types of nerves. Now, the first thing that we obviously do in patients who come to the spine center, to our office, with any of these symptoms, such as pain or numbness or tingling or weakness, the first thing that we do is we get a good history and a physiological exam and a neurological exam. And I want to ask maybe to start, and then I'll try to say as little as possible for the remainder of these 45 minutes. I want to ask Dr. Weaver, who is the neurologist in the spine center, maybe to summarize what a typical exam would look like in a patient with back or neck pain, and how we can conclude from an exam where that patient's pain or neurological problem is coming from. Josh, are you there? Whoop.
Yes, I am here.
Yeah.
Thank you for that introduction, Dr. Härtl. So I'm Dr. Weaver. I'm one of the neurologists at the Spine Center. And we obviously see a lot of patients here with neck and back pain. As Dr. Härtl mentioned, actually the first most important thing that we do is get a good history. We actually ask, what is the pain like? Where exactly do you feel it? Does the pain radiate anywhere into the limbs or around the torso? What makes it better? What makes it worse? And we go through all of those things with people. We also want to make sure we find out, again, Dr. Härtl mentioned these things called red flags. So we want to think about certain conditions where we'd be particularly concerned: a history of cancer or a suppressed immune system, fevers, weight loss, things like that, which might mean that there's something more sinister going on. But neck and back pain are extremely common. As far as the exam is concerned, we start with just inspection of the back, kind of like what they're showing here. First, we just, we'd hope to take the shirt off and actually look at the back. We want to look to see is there any scoliosis or curvature of the spine. We want to check range of motion, see them flex forward and extend back. Next, we would palpate the spine. You actually touch, like they're showing on here, we touch the spine. We try to see if there's any tender points along the bones or the musculature that's surrounding the spine. Sometimes pain can be due to muscle spasm, and it can be pretty debilitating. And sometimes you can actually feel the tightness and the spasm of the muscles. The next thing that we do, and that I do a lot as part of the neurological exam, is looking at the strength of the legs, the sensation in the arms and the legs, and reflexes. We look at the knees and we tap the knees, but we also look at reflexes in other parts of the body as well. All of those things can tell us if there's nerve involvement, if there's spinal cord compression, or if the nerve roots coming out of the spine going into the arms or legs are affected. Another thing that we commonly do, and we'll see examples of these a little bit later, are what are called provocative maneuvers. Sometimes we try to put you in certain positions that might bring on the pain that you're feeling, because that then tells us in that position, it might be a part of the bone, like the joints on the side, like the facet joint, or it might be a compressed nerve. So there are certain maneuvers that we also do during the exam.
Josh, that was a really nice summary. And I see a lot of familiar names in the audience, and I see some faces that I know, which is great. Thanks for calling in. Marsha Rickles is asking hip joint pain. How do you differentiate that? How can a patient that you see in your office, rather than a spine problem, can that actually be coming from the hip? And what gives you an idea where that pain is really coming from?
So that's a really great question. And again, the same principles sort of apply here, although this is the whole point of this talk, is that sometimes it can be very tricky to sort out, just based on where the pain is described, where it's actually coming from. Sometimes people have hip pain, but it's actually coming from the lower back and radiating into the hip versus hip pain itself. So again, palpation can be really helpful, and we can palpate not only the spine, so touching the spine, but also putting pressure on certain areas of the hip to see if there's pain elicited there. There's also a maneuver called the Patrick's maneuver, which I do sometimes, where you have the patient lying down, you lift their leg and you kind of put them in a frog leg position. So you sort of bring their leg over to the side with the knee flexed. And sometimes that puts strain. You're kind of opening up the hip joint when you do that. And if you can recreate the hip pain that way, that's one way you can sort out, if it's just the hip versus the lower back. So there are other maneuvers and things like that that can be really helpful.
That's great. And we have a question regarding facet joint pain. And I think that is a good opportunity to transition over to Dr. Mehta, Neel Mehta, who you can see here in the video as well. Neel, is your microphone working? Is that?
Are you able to hear me?
Perfect, perfect. It's nice.
Okay, great.
So Neel is works in the spine center, pain management, obviously. So go ahead and tell us a little bit about facet joint pain or the other things that you do to diagnose patients.
Well, thank you very much for having me here, and it's a pleasure to see everybody here. And people, I'm watching the chat room and seeing some great questions come through. And one of the great things about working here at Weill Cornell Center for Comprehensive Spine Care is that we all are sitting literally a few feet apart, and many of our patients will see more than one of us in a particular visit. So it's not unusual that you will have multiple visits in one day to help determine not only the diagnosis, but a treatment plan. Much of what Dr. Weaver has talked about in the exam part, we also perform, but sometimes it still lends a question as to what could be a source of pain, given that physical exam isn't definitive, and maybe even interpretation of imaging. And so we'll use injection or procedure therapies to help us rule in or rule out types of pain. And the first picture I put up here on the left is a facet joint. These are the joints that allow us to bend in our spine. They're located in the lumbar and thoracic and cervical spine. Most people have troubles with this in their facet joints of the lumbar and cervical spine. And one thing we'll do is we'll try to do a nerve block of something called a medial branch. And the medial branch is a small sensory nerve. Its sole purpose is just to detect pain. It does not control any movements of your arm or legs. And we can use a very small amount of lidocaine purposely targeted with X-ray to a specific joint to determine if pain is coming from that particular level. And it's pretty immediate. You'll have the block, and probably within a few minutes, we will see if there's a difference in pain. We may have more than one joint targeted, and we then can go on to make an assessment of whether that particular joint is involved, and may have more definitive treatment with radiofrequency ablation. So this would be in the broad category of a axial back pain or more focal back pain that may also even radiate into the legs or arms or upper back area if we're talking about the cervical space. At the same time, it's not unusual if somebody comes to us with complaints of pain down an arm or leg, and on review of imaging, we find that there's more than one particular area of either disc herniation or narrowing of the spinal canal, especially at the foramen. And so we would need to have a more accurate diagnosis. So we'll consider a injection of steroid or even local anesthetic at that particular level. So if we focus on that, it could be that it's a foraminal injection that we're targeting rather than the joint, but now targeting that particular nerve root and seeing if that pain does go away afterwards. So if we can advance to the next slide, we also can target other areas of back pain, like the sacrum or the SI joint, sacroiliac joint, that could be a culprit of back pain in many patients. So doing a diagnostic and potentially therapeutic injection of local anesthetic and steroid with imaging guidance, you can determine again if pain is related. So partly this is related to our physical exam to confirm our diagnosis, or if there's uncertainty, we then use this as to try to be more definitive. If we go to the next slide there. This again is on the right is talking about the SI joint, but on the left, we then can use injections that are focused on joints, in this particular case, the hip, that can help us rule out causes of hip pain that could often overlap with causes of back or leg pain. And it's not unusual for patients to have imaging that shows back troubles, but also arthritis of their hip joint. And this, again, helps us differentiate between the two. So again, in summary, it's the guided injections with the use of local anesthetic under X-ray or ultrasound to help us rule in or rule out pathology that can guide further treatment.
Yeah, Neel, thank you for the summary. So we heard from Dr. Weaver about the neurological exam, which is obviously the most important thing right in the beginning, the history, the neurological exam. And then if it's not clear based on that and based on the imaging findings, and usually we work a lot with MRI scans because they show you the nerves the best, then we may get Neel involved, and he can help us with those focal injections. He can tell us, is the pain coming from the SI joint, from the hip joint, from the facet joint, and so forth. But Neel, tell us now, if you do a diagnostic injection, let's say you do a diagnostic, I see from the comments here, a number of listeners have problems with the SI joint. You do a diagnostic injection for the SI joint, and that actually helps really well. What's the next step for those patients? Let's say they come back a week later or a month later, and they still have the same pain, or they have the same pain that came back.
That's a great question. So SI joint in particular, we then stop and think about what may be the underlying pathology of causing that recurring pain. So we've demonstrated that you have good relief, but it's temporary. So is there some sort of chronic inflammation or some sort of chronic laxity or movement of the joint that's causing that pain? Is there some sort of trauma that needs to be addressed, like a sacral fracture? And so those different things get looked at and determined. So let's say it's a movement of the joint, and that there's the medical term being laxity. A recent innovation in this space has been to fuse that joint, this SI joint. About 10 years ago, that was considered to be a very major operation with a long recovery period and significant pain. These days, they have percutaneous ways to do fusion of that SI joint as same-day procedure, some under even local or sedation anesthesia to fuse that joint and relieve that back pain. We've also done radiofrequency ablation, where just like the facet joints, there are sensory nerves that can be heated with electrocautery and try to quiet those nerves down for several months. And then there's been some growing research in the use of platelet-rich plasma or even stem cells, and the idea of trying to fortify this and regenerate that joint. So an area of interest, a lot of work being done in it, but good treatments available today.
Yeah, there's a question from Wendy Gibbs. How do you fuse the SI joint as an outpatient? Since I'm the surgeon, I'll just tell you, it can be done with a minimally invasive procedure through a small incision. And those patients typically will go home the same day if they live local. And obviously, if they have somebody at home who can watch them overnight. Can SI joint cause hip pain, Neil?
Yes, for sure. SI joint, especially if we're talking about posterior or sort of back and hip pain, it certainly can be related to SI joint problems. Again, part of the exam, the workup would look at the hip joint itself and other potential causes for that pain in the buttock area. But yes, it can be related.
Good. Now, I can see Dr. Weaver, our neurologist, is getting bored, and we're going to ask him a few questions as well. And now this is a picture that shows you compression of a nerve that travels down from the spine into the legs, and that nerve is being compressed by the piriformis muscle. And many of you have probably heard about the piriformis syndrome. Josh, what can you tell us a little bit about that?
Sure. So this is actually a kind of a controversial diagnosis. Some people feel it's not as real as others make it out to be, but I actually believe in it. I think it is real. The piriformis muscle is very posterior, so it's in the sort of buttock region in the pelvis. But when the sciatic nerve comes down, as that picture is showing there, the piriformis muscle can compress the nerve, sometimes against the bone, but many times the sciatic nerve even pierces the piriformis muscle. So for various reasons, the piriformis muscle may compress that nerve. We do see this in people who maybe are very athletic and might actually kind of overwork some of their gluteal muscles and posterior pelvic muscles. Rock climbers, for instance, this is something that you might get actually bigger muscles in that area. So sometimes you can see it that way. You know, there are ways we can sort out if there's a sciatic nerve problem. But as you can imagine, you know, you can see how close on that picture where the nerve roots are coming out from the spine. It can be difficult to tell if it's coming from the piriformis itself versus from the lower back. Sometimes a nerve test that I do called an EMG can be helpful in trying to figure out where the compression might be. Imaging can also be useful to look at the lower back. And lastly, you know, Dr. Mehta, he brought up a lot of injections and how they can be useful not only to treat the pain, but also to diagnose where it's coming from. There are actually injections to the piriformis that you can give to see if that helps relieve the pain. So all of these ways are possible in terms of trying to figure out where the problem is.
Yeah, and I actually just saw a patient today who had a spinal operation done years ago somewhere else, who had very, very significant pain deep in his buttocks. And we did a piriformis injection, and he just texted me that his pain is totally gone after many years of trying to figure out where that pain is coming from. So it's something that we see every once in a while. You got to keep it in mind. It is somewhat rare, but it is quite impressive to see how patients actually do well when diagnosed appropriately. Now, we're going to move on to our next topic, which is muscle as a source of pain. Now, we talk a lot about herniated discs, about joints, about the facet joint, about other structures. What about the muscle? The muscle is probably the largest organ that we have in our body, but we haven't really understood that the muscle itself can sometimes also cause pain. And one of the most, in my opinion, one of the most exciting pictures or scientific discoveries really is the relationship between intensity of it, so sports essentially, and the risk of low back pain. There's a sweet spot here. If you don't do any activity, if you're totally inactive, you have a high chance of developing low back pain. If you're doing too much, again, your back pain risk is going to go up. But there's a sweet spot in between where you use your muscles, you do sports, and those patients actually have a much lower incidence of low back pain. And that has to do with healthy muscle and musculature. Neel has done a lot of work on this, and Neel is really an expert when it comes to muscular pain and the diagnosis and treatment. Maybe you can tell us a little bit more about this, Neel.
Yeah, I think it's important to hear a little bit of context of where muscle pain came about. From my mentor, Dr. Norman Marcus, who has treated muscle pain for decades as part of his practice. He would tell me about treatment of President Kennedy, where President Kennedy had all access to care available to him in the White House, including surgeries and injections and so forth. And finally, what was helping him sort of before his unfortunate demise was treatment of his muscle pain. And I think that this is often overlooked. The muscles, such as, like, say, the quadratus lumborum or the multifidus muscles that are located in the back, often are potentially causing pain because of a number of reasons. They could develop spasms, they could have tension or stiffness. You could have trigger points that the muscle is locking together, or often it's just not strong enough. People don't have core strength or other ability to engage those muscles, and it leads to pain. And often patients that have no pathology on an MRI are realizing that the muscle may just be a larger component of that. So part of our work up here in the Spine Center is to examine those muscles, look at physical fitness and flexibility, areas of spasm, and then try to hone in on which particular muscles may be focused there. So we use some topical treatments and some oral pills to try to help. And then we also evaluate if the patient has other areas of muscle pain, if it's just focused on the back, or is it more widespread through the body? Because we're realizing that there are a number of people that suffer from hypermobility, or being extremely flexible to the point that it causes injury. Maybe even a subset of patients that have Ehlers-Danlos syndrome. So again, muscle pain is a unique thing that we are focusing on here at the Spine Center. It does require an in-person evaluation and to be comprehensive, but I'm excited that my peers here are all learning together about muscle pain.
Yeah, and you bring up the telemedicine inpatient versus telemedicine visit. We all do telemedicine visits. I used to see patients 2 days a week. Now I see them 1 day a week, and then the other day is just telemedicine. And I know that everybody here, we've got 16, 17 doctors in the Spine Center. All of us do telemedicine. So even if you're not local, if you're out of state, or you're just worried about coming in, we can do that. But be rest assured that everything here is being done safely, and we follow all the guidelines to make sure that if you come in, obviously we are safe, and we protect you and the health of yourself and the people who work here. Now we want to move on to another problem that we see frequently in patients, and this is an MRI scan. Again, I don't want to confuse you with MRI scans too much, but I think it is interesting, because this is a normal MRI scan of the lumbar spine here, and down here there are 3 different patients with 3 different synovial cysts, and they're really sitting like little golf balls in your spinal canal, and they're compressing the nerves, and they're filled with synovial fluid, which comes from the facet joint. And these can form for all types of reasons. Sometimes it can be an expression of instability of the spine, but it may not. And maybe let's hear from Neel a little bit more about synovial cysts. What can you offer patients for treatment, or for also for diagnosis?
So synovial cysts sort of mimic what a disc herniation is. As this cyst or this balloon-like structure starts to enlarge, we worry about the compression of the nerve roots that are in that vicinity. Why do they develop a cyst in the first place? Well, there may be some sort of movement of that particular facet joint, and that leads to this formation of a balloon. And then as more joint fluid gets in there, and over time, potentially, it gets large enough that it can compress on the nerve. What do we do for it? Well, once we have a diagnosis and looking at it on imaging, we do try to put a needle into that balloon, which can be done percutaneously. And we try to drain it. We can actually get joint fluid out of it. If I'm successful in getting fluid out, then I'll take a little bit of saline and try to put pressure into the remaining part of the balloon and even try to rupture it, depending on the size and how compressed the nerve is. If it's too large and it's worry that the patient's going to have significant pain with putting more saline in, then I don't do that. And then if there's pain related to the cyst and there's irritation of the nerve root, we'll often follow up with an epidural to try to relieve some of that pain. Now, if we are successful, great, but there is a chance that the cyst may return despite our best efforts. And so then I correspond with our surgeons, and our surgeons here, like yourself, Roger, can very easily take out that cyst without taking out too much of the joint, a quick surgery that has a very quick recovery as well. And then you have a more definitive treatment.
Yeah, this can certainly be treated with a minimally invasive operation very successfully. And these patients sometimes go home the same day. Years ago, I had a malpractice lawyer who had 2 synovial cysts, and he was scheduled for surgery. And interestingly, the cyst disappeared maybe a week before surgery, so we canceled the surgery. So that's another thing to know, that these cysts can come and go within days. They can just burst even without treatment if you're lucky. But if not, if they cause you a lot of pain, then surgery is certainly a very viable and successful way of treating these synovial cysts. Now we have a patient who asks about lumbar L5-S1 disc herniation and how to work that up and how to potentially treat that. And I think the next slide is actually a nice example of exactly that pathology. And I'll ask Josh maybe to comment a little bit about what this is and how do you work this up diagnostically, and how can you figure out where this patient presented. This was a patient I treated maybe 10 years ago, a very active person who was a runner who had severe right-sided low back and leg pain.
Yeah, so first of all, even before we get an image like this, you're going to see a patient that has really characteristic findings when they tell you what's going on. So they'll say exactly what you said, Dr. Härtl, is that they'll have back pain radiating down the leg. And if it's affecting certain nerve roots, it will go to certain areas in the leg usually. So when we see a patient and they say, my back pain runs down the back of my leg and kind of wraps around the side and goes to the front of the foot, that would be consistent with an L5 nerve root, and that because that's the skin area that root sort of supplies. The S1 nerve root is what we typically think of, more like sciatica in terms of pain radiating down the buttock and the posterior part of the leg, sometimes going into the calf and into the ankle. So when we hear that story, that's a very, very good story for what we call radiculopathy, which is just a pinched nerve, at the lower part of the lumbar spine. Another, part of what we do, again, when we go back to the exam, we look at, different strengths of different muscles. And so we look at, the foot muscles in particular, as well as the hamstrings in the back and the calf muscle. So we look at all those muscles because a lot of those muscles are supplied by L5 or S1. And we can see if there's any motor weakness due to nerve injury. Same thing with sensation, and the same thing with reflexes. We can get a sense of where the problem might be coming. Then we would get an MRI like this. If we think, I really think this is it's a compression of the nerve root, And we might see, for those of you who aren't sure what we're looking at, you know, the last two, well, there we go. So this is another way of looking at it. So that dark, if we go to one before, the disc that you see there is nice and round. There's nothing bulging out anywhere. That white area below that is the spinal canal, and all those little dots are the nerve roots that are in the spinal canal that haven't yet left to go out to the legs. And then in the next slide, you'll see, boom, there's this big bulge on the side there that's pushing on those nerve roots as they're trying to get out to go to the leg. So that would actually then, this is a very typical scenario. If we had a patient that had those symptoms and we get an MRI that looks like this, I think it would be pretty clear what was going on. And then we would have to discuss how to treat that.
No, Josh, if this patient shows up in the spine center, let's say he's a 45-year-old gentleman, runner, very active, has family, little children at home, severe leg pain. Now you're in the spine center, you have 15 other doctors there, they're all waiting for you to send them a patient. Where you go, how do you decide whether to send this patient for an injection or just for physical therapy, or you're going to send the patient to the surgeon? How do you make that decision?
Well, first of all, if you remember the picture about the gears, the neurology was in the middle because we are the most important. So,
of course,
you know, I make these decisions after that. You know, it really depends on the situation. So really severe pain, oftentimes, you know, they will require, you can't sit around necessarily for 3, 4, 5 weeks for physical therapy to take effect, even though it can be helpful. And I may, in those cases, if it's very severe pain and it seems like there's a clear reason, send them to a pain management doctor for an injection to see if we can help with the pain. Now, if I see on the MRI that there's a very severe disc herniation, the concern will be nerve damage. And often we can pick that up on an exam. If I see that his foot is weak, even if it's just the toes, if there's weakness there, or God forbid there's any bowel or bladder problems or anything like that that tells me that there is some sort of nerve damage going on because of that, you really don't want to sit on that and wait around, because eventually that nerve damage might become irreversible. And I think in those cases, once I get a hint that there might be nerve damage going on, that's definitely when I get a surgeon on board very quickly. If I saw a disc like that, I would probably get a surgeon on board soon anyway, even if they get a lot better with the injection, because there's a really high risk that could eventually cause nerve damage over time.
Yeah, thank you.
I should say, Roger, that we just had a case in common. I think just no more than a week or two ago, where a patient, severe leg pain, very, very limited in what she was able to do, actually did not have an epidural, and we sent her straight for surgery for a microdiscectomy. It all depends on what the clinical scenario is there.
There's one listener is asking about, what about sciatica pain that switches sides? And that is an interesting question, because here on this MRI scan, you can see that nerve on the right side is, you know, what I'm pointing to is actually the right side is switched around on the MRI scan. So this patient has right-sided leg pain, but sometimes the disc herniations are so big that they can actually reach over to the nerve on the left side, and that patient could actually have left-sided leg pain as well, even though the disc herniation looks bigger on the right side. So yeah, those things can happen, and that's why diagnosing these patients is such a challenge, and it's really like a detective story sometimes, and requires input from the neurologist, maybe get an EMG from Neel and some of the others, maybe do a diagnostic injection or a nerve block to figure out exactly really where the pain is coming from. Now, and then surgically, what we do is we go in, and that is really one of the most successful operations that we do. We go in through a little incision and remove the disc, and you can see that here in this drawing, and take the pressure off that nerve. And but again, you want to do it for the right reason at the right time. You don't want to over treat, of course, either. Now, this is another MRI scan, and this shows very nicely a patient who has severe lumbar spinal stenosis. And maybe we'll have Josh again talk about lumbar stenosis. How do you see, you know, these patients in the office? What are the typical symptoms, and what are your diagnostic considerations?
Yeah, so this is a really interesting picture that you put up here. And this is often what we see, especially as we get older. We often have MRIs that show a lot of changes at a lot of different levels. So you can see here, there are disc bulges at almost every level on there, as well as bony changes and ligament thickening from the backside, all of which is sort of compressing the spinal canal. The picture on the right there is more limited to one area in particular. So when we see, though, the lumbar stenosis, and by that we're talking about the middle part, the cervical spine, the lumbar spine being tightened in the middle, what we call lumbar stenosis, we see people with back pain, but particularly the pain tends to be worse if they're standing upright. It tends to be a little bit better when they're flexed over, because when they're flexing, it kind of opens up the canal a little bit. There's something called a shopping cart sign that we often hear about. We'll see patients, some patients will actually prefer to have like something to hold on to. So if they go grocery shopping, that shopping cart and bending over will be helpful. It'll relieve some of the pain. The pain may get better if they sit on a chair and sort of have a forward flexion, or if they're lying down. And we often get a history of something called claudication with stenosis. So initially you can walk for a block, 2 blocks, whatever it might be, but when you have stenosis and you're in that upright position, those nerves get more and more irritated, and they start to cause more and more pain shooting down into the legs. And when that happens, it can get to the point where you actually have to stop walking and rest, and you have to sit down, and then you start to feel better and you move on again. And that's what we would call neurogenic claudication, and that's a pretty telltale sign of lumbar stenosis. So when we hear things like that, again, we would get an MRI to see what the problem is. A nerve test or an EMG would also be able to tell us if there's nerve damage due to the stenosis. And again, the examination would be really important. But there are many ways we can treat stenosis. Again, depending on the case, physical therapy, injections can be helpful. Sometimes, though, if there's real weakness or bowel or bladder problems, again, surgery may be the answer.
Yeah, and this can be treated with a relatively small operation, minimally invasive as well. Especially in these cases, you can see that patient doesn't have any spinal instability. This is a very straightforward thing to treat with MIS or minimally invasive surgery. Now we'll talk a little bit. We have about 10 minutes or so left. We have only 2 minutes left. We'll talk a little bit about cervical spine. Cervical spondylosis, what can cause neck pain and cervical pain? Maybe Neel, maybe you can talk a few words about what we see here.
Yeah. So number one, for cervical spine, part of the examination is to help differentiate between, is the pain more focused on the neck? Does it radiate into the back of the head in the occipital region? Does it radiate to the shoulders, upper back, or even down the arms? That's how I first started break down. Is it a problem of a disc herniation? Even before we have imaging, I try to think in my head what I would expect to find. Or is it a problem of arthritis of the joints? Again, facet related pain. That may be more confined to the neck, may radiate to the back of the head, maybe even into the upper back. Is it myofascial? Is it that muscular pain is causing this? That movements of the neck generally don't cause pain, but there is stiffness, and there's a lot of tenderness on palpating the muscles. So, those are different things that I look at. In terms of treatments, again, from the really basic, beyond physical therapy and the use of TENS units, topical creams, we may think about injection therapy if it's facet related, or even an epidural steroid injection. We also have a new program here treating myofascial pain, where we're using a laser for a course of about 10 sessions to try to work on myofascial related pain. So in this particular area, we'd be most concerned about whether there is facet-related arthritis or movement. And if there is some sort of instability, then we would obviously confer with our surgeon colleagues there if surgery is most appropriate. But again, a multidisciplinary approach. I also think, Roger, we should talk as we're winding down about the process besides just patients coming in, getting evaluated, potentially seeing more than one of us. We just finished our spine conference. Every Wednesday, we present for an hour to discuss cases with a multidisciplinary team. That includes the folks that you see here today, a psychologist, a radiologist, physical therapy, and try to get a consensus on what we think is the diagnosis and best course of action. And then that is relayed back to the patient as part of a multidisciplinary evaluation.
Yeah, that is very important. And that is indeed one of the highlights of our week here when we talk about some of the patients that we evaluate. At the end, there were a few in the audience who had questions. There was somebody, Zorai, I think. Can we unmute him or her? Had a question. Roseanne, if they're still here.
Yes, I just unmuted Zorai, if you'd like to speak.
All right, Zorai, you're up. Okay. Well, I think we're gonna wrap up. It's we've been on for 45 minutes. We've had a lot of really exciting questions. If we didn't get to your questions, we apologize. Send us, call the office, send an email. We try to get back to you if we can. If not, the best way to stay in touch to dial back in 2 weeks. So thank you everybody for listening. Thank you, Neil. Thanks, Josh. And
Thank you, Roger.
We'll meet up again in 2 weeks. All the best. Stay safe, everyone.